Okay, I want to welcome you again to today's tutorial. My name is Geoffrey Mtale, as usual, and today I will be taking you through specimen grossing. We have been discussing a number of topics, and as we continue to discuss, I want to thank you and encourage you to always share and press on the like button, and then subscribe to my YouTube channel so that next time when I post a new video, you're able to get a notification and follow through in what I've discussed. So today we are going to discuss about specimen grossing. What is grossing and what is done in a grossing room, what we find in a grossing room, the importance of grossing, and other things as we shall continue to see. So when we talk about grossing, simply we are referring to the macroscopic examination of the tissue with our naked eye without the use of a microscope. We are going to look at the size, we are going to look at the color, we are going to look at the texture of the tissue, and then many other things. So when we do tissue grossing, one, it helps us to identify some points of interest, like we can actually be able to identify some lesions macroscopically or suspicious parts on the tissue that could be lesions or tumors for that case, and we can mark them out, and this will aid in the following steps in processing the tissue and finally making the diagnosis of the cancer when we are examining the slides after preparation and taking through the tissue process. So grossing, just like I mentioned, this is the macroscopic description of the tissue, and it entails the description and giving information that aids the pathologist in making diagnosis during microscopic evaluation of the tissue. It includes cutting smaller pieces of the tissue from the entire gross specimen which is submitted to the laboratory. Like for example, we may receive a mastectomy, we will receive a breast in the lab, and like we have been looking at in our different discussions, we cannot put the entire breast into a cassette and process it, but we have to pick a sample. So it is during the process of grossing that we identify specific areas on the breast and cut out those smaller pieces, or identify the lymph nodes or any other suspicious part on the breast that we pick, and then we process that for sectioning and eventual examination or evaluation in the microscope. So these pieces of the tissue are likely to be more diagnostically significant in relation to the entire specimen and are placed in tissue processing cassettes for processing. So when we have our tissue, the big tissue that has been provided to us, we do not just pick any part, but we go for significant parts which are diagnostically important, that we suspect to be having the tumor, and eventually those which produce results which will be very important in the management of the patient. So an accurate diagnosis from the tissue is actually dependent upon the correct identification during grossing. That's why we need some technical competences here now when we are carrying out grossing, because if we pick a part of the tissue which is not diagnostically important, then we may actually miss out and have wrong negative results, claiming the patient doesn't have a cancer, but when actually during grossing we actually picked out part of the tissue which was not very diagnostically important. So we carry out grossing in a room we call a grossing room. This is a special room which is well equipped with different equipments, and the purpose of it is to carry out grossing before the specimen is leave or the samples leave to go for other steps in tissue processing. So we need, in this grossing room, we need to have a ruler with millimeters or with a millimeter scale. because just like I mentioned before, when you talk about grossing, it is going to be macroscopic examination. So we need to describe the tissue we have in terms of length. So we need to now measure the tissue we have. We can measure its length, and we say probably we have measured the tissue and the tissue is measuring 50 centimeters, 50 millimeters for that case. Number two, we may need the magnifying lens, because some features on the tissue may be very small to be identified with the naked eye. So when we have a magnifying lens, we can be able to identify such features and then record them down. Number three, 10% neutral buffer formalin is very important, because sometimes we do grossing on tissues which are very fresh. So tissues could be fresh and not properly fixed, though some tissues are actually grossed when they have been fixed, but some tissues will come when they are not actually fixed and they need to be grossed straight away. So we need to have 10% neutral bufferin. Actually, even those tissues or those samples which have been already fixed, after grossing and identify and cutting out these small parts which are really significant for diagnosis, we don't let them dry out. So we keep them in neutral buffer saline, so formalin. So we need to have formalin around. We need the waste bins, because we are going to have a lot of wastes, a lot of what we cut off and what remains of the tissue. So we must have where to dispose of the waste. The sharps, we are going to be using scalpels, blades, and these, after we have used them, we need to dispose them off. So we need the sharps container as well. We need disinfectants, so that we ensure that the place where we are working from is actually disinfected to avoid infections. You remember we are handling with samples, and some samples come when they are fresh before they are fixed, so they are highly infectious. We need a weighing scale, because at some point we may need to weigh the tissue and then describe its weight. We need the measuring cylinder to measure the volume of the fluid we have been given, because sometimes we receive liquid samples or fluid samples and we need to measure their volume. We need a camera. With the advent of technology, we need to capture the real image and store these images, because these cameras help us to store and actually they help us to look at the actual description of some of these tissues, like the color. You see, sometimes there could be inter-observer variations in the color. Somebody may report yellow, and then another pathologist may actually report cream. So depending on who actually is grossing the specimen, may have deviation or inter-observer variation when we are reporting. So to keep the original appearance of the specimen, it is always important to capture images, real images of the specimen using the camera. So some grossing stations are well equipped, they are very modern, and they have the cameras on them and can be able to take images, take pictures of such specimen, and then we store them. So we need a pencil and pen for labeling cassettes. We label cassettes with the tissue identifiers, and this should be the same which are appearing on the request form accompanying the tissue. So these numbers will follow through the tissue, all the process, all the steps in the process, from when we are grossing and label them on the cassette. This is the number which we shall have assigned to the tissue when it was received at the reception. It is the same number which you are going to push to pass on, or the number that we're going to include on the cassette after putting the tissue in it, and then this number will follow the sample up to the time the results are out. It will be the same number which is going to appear. So we need tissue cassettes. These are the most times plastic, and these cassettes, this is where we are going to put the smaller portions of the tissue that we have identified to be diagnostically important. We place them in the cassette, close well. You remember we have labeled our cassette, and then we put them in the formalin, and they will be ready for other steps of processing. Then lastly, we may need glossing ink. This glossing ink is actually important in labeling the margins on the samples. We may wish to identify the superior margin, the inferior, and other margins. So using the glossing ink, we can actually ink the margins of the specimen for easy identification. So continue with the requirement for glossing room. We need a sink with tap water because we always need to clean our working stations and even wash our hands. And yes, we cannot operate a lab without water. This we know very well. And on the chopping board, on the glossing board, we shall need to always flood it with water to clean, and actually we avoid having unnecessary mixing up of samples. So we need to keep it very clean. We need a fume extractor. You remember we are handling samples which have been fixed in formalin, and there are actually formalin fumes which are getting out of the samples we are handling. So we need the fume extractor to reduce on our exposure to formalin. We need surgical blades and scalpels, and these are important for cutting out small tissues or cutting open the tissue to see the inner surfaces of the tissue we have, or to do bread loafing, like when we have big samples, like for example the breast, we may need to open it and cut it into small pieces to open it up so that formalin can properly enter and we have good fixing. We need to have glossing knife, scissor and forceps, and sometimes we need to have hacksaw because this is going to be used for cutting some hard tissues, like for example bones. If you want to cut them into smaller pieces, then we need the hacksaw to cut this tissue into small pieces. We need the formalin absorbent pad. This is going to be used to absorb the formalin so that we do not expose ourselves to a lot of fume. We need the waterproof apron. You remember we are going to be dealing with fluids and some chemicals. We are picking samples or these specimens from formalin, and there are possibilities of having spills. So to protect ourselves from having direct spills on our clothes, we need to have the waterproof apron. Masks are important, gloves, it's obvious, and then we may need the glossing board from where we are going to be cutting. So on this image here, it is displaying some of the tools that we have in the glossing room. So if we are to just mention a few, we'll look at these plastic cassettes here. These are the ones we are calling cassettes. So these are cassettes where if we have identified the diagnostic part, we cut out that part which is small enough, approximately 3 to 4 millimeters, and then we put it in this cassette. We close very well before we take it for further processing. So we have scissors of different types, and then we have blades here, we have the scalpels here, we have forceps which we use for picking out samples, we have a ruler in millimeters which is used actually for measuring the length of our specimen or our samples, and then we have a knife because we need to cut out some pieces or cut open some tissues. Like the example I was giving about a breast, we need to open it up, and we can use a knife to do bread loafing. So in this next image, we have an example of a glossing station where we are going to do our glossing from. So we talked about a number of things, but to start with, there is a glossing board. Let me get my pointer and then point on it. So this is what I was referring to as a glossing board. It is the same or almost the same like the chopping board we have in our kitchens, where we used to cut and prepare our spices, tomatoes, even cut meat when you are going to prepare in the kitchen. So the same we have in our glossing room at our glossing station. So we talked about having a lens. So we have a lens here. We can bring it closer so that we can look at our image, at our tissue, properly identify those significant areas of interest. that can help us to identify the part of diagnostic interest. We have tap water here, and this tap, there is free flowing water when you open, and then we have a number of tools. We have the weighing scale here, because we may need to actually measure the weight of the tissue. We have ink. If we can look here where I'm putting the mark here, where my pointer is, that is ink. We have gloves. So this is a grossing station which is well equipped. We can look at another image and see different features. So here we have the source of light. These are light sources. We have light here where my cursor is, and then we have a light here. We have a lens here, and this can actually flash on the sample so that it can provide enough light for us to identify specific points of interest on the tissue, so that we can easily identify which part of the tissue we are actually going to cut out and put in the cassette for further investigation. Yeah, some stations are also equipped with cameras, and these cameras, they will capture the image in real state as it appears, and then it will be displayed on the on the computer, like you see on the monitor there. So some grossing stations are that advanced. So now here we are looking at some tissue which have been cut out during the process of grossing. So the pathologist here who was grossing at the station identified the certain portions or certain parts on the tissue, and then cut out small parts of the tissue. And when we look at this tissue, this tissue is even marked with ink. We are seeing black, something appearing like black. I think it was actually marking out the margins. So we cut out the tissue which is small enough to fit in the cassette very well. We do not want to cut out big pieces of the tissue which will not actually fit in the cassette, but we need to cut out small portions of the cassette, of the tissue, that are actually going to fit well in the cassette. And when we are putting these tissues in the cassette, we need to orient them very well. Actually, sometimes when we receive the samples, the surgeons will have marked the margins for us, and we would love to maintain the same orientation of the tissue. We carry it, or we pass it over into these cassettes, and still when we get to other process like the process of embedding, still we need to reorient the tissue the same way they were oriented just right away from the surgeon after he had excised the tissue and sent us. The way he labeled it and the way he marked it, the way he oriented it, we need to maintain it. So here we are looking at tissue, we are looking at tissues which are placed in the cassette. So we need to note that they should not actually fill the cassette and must permit or give room for processing fluid to circulate, so they should not be big enough. So the orientation, just like I said, of the block is enhanced by a sponge securing the specimen in the sequential position. So we have some cassettes here, we have which have blue sponge. So this blue sponge is going to help maintain the position or the orientation of the tissue in the cassette, so that it doesn't change. You remember these are plastic, and the tissue, after it being put in formalin, after being fixed, it hardens a little bit, so it may keep moving or slide off the base of the cassette, and it may change the orientation. So when we put a sponge at the bottom, it can help to maintain the position and keep the tissue in one place. So we need to look now at the general principles or the rules of grossing the tissue. So number one, there should never be more than one container open at a time to ensure that each specimen is returned to its appropriate container, so that there is no chances of mix-up. So when we pick this tissue and we have identified the portion of interest which we think is diagnostic enough, the remaining part of the tissue is not thrown away immediately, but we are supposed to put it in its container until results are out or even keep it for some time depending on the policy of the lab that they set out. Because if you throw it away and we need another sample, we can easily retrieve the remaining piece of the tissue and then cut out another piece of the tissue and process it for examination. So to avoid mix-up, because if you open many containers at the same time, you may end up putting your tissue in a wrong container, thinking you're putting it back in the original container. So at least ensure only one container is open at a time. Number 2, qualified staff should do the sampling of the specimen, because with experience you can look at the tissue and be able to identify parts which are suspicious of having lesion. Where you see where there is a blood on the tissue, like for example, I'm not saying wherever there is, but just to give an example, with experience we can identify. We can look at the texture, we can look at the color of the tissue and be suspicious. So we need an experienced eye here. So it is recommended that we have a qualified staff and who has experience in identifying to do the grossing. So grossing of the specimen can also done either before or fixation. I mentioned this before that there are some tissues or sometimes we can do grossing on tissues when they are fresh before they are fixed, or otherwise we can actually do grossing on tissues after they have been fixed. So it is also ideal to gross large specimen in a fresh state and smaller ones following fixation. So continue with the general principles. The next bullet talks about that the sample should be described in terms of shape, in terms of size, color, texture, and then defining the characteristics of the specimen. Is it round? Is it oval? Is it hard? Is it capsulated? The size, how big is it? That's where we need the ruler, because we need to measure its size and say it was measuring 5 by 6, 10 by 40, like that. The color, is it white? Is it cream? What's the color? And then other description that we may identify on the tissue. So all these descriptions are important because we are looking at the macroscopic examination and the identification of points of interest on this specimen. So this means that small biopsies, for example, like the endoscopic mucosal samples, this may simply be afforded a simple descriptor in form of the number of pieces. Like you can report that I received 5 pieces of the biopsies, and all together you put them together and then you measure at once instead of measuring one by one, because they could be too small to be measured and they could be many in number. So you can bring them in one position and then you give them a simple descriptor altogether. You received the 5 altogether measuring either 5 millimeters or maybe the biggest measuring this by this, and all possibly put in one cassette. Like for example, we have an example here that you received the 3 pieces of brown tissue and the largest measuring 3 diameters, and they all put in one cassette. That's a descriptor which can actually generalize those small pieces of the tissue. So a properly completed surgical pathology requisition form containing the patient's identification like age, sex, essential clinical data, nature of operation, surgical findings, tissue submitted, and the site of biopsy specimen should accompany every specimen. And these are this is a very sensitive information that you shouldn't miss. Actually, should you receive a specimen in the lab and you're probably the one grossing and you realize such information is not there, that sample should not be processed, because whatever we are going to do at the end when we're examining our site, we must relate it with this information. We need to know the age of the patient, we need to know the sex of the patient. These are all going to guide us on what we are going to look for or in making our conclusions. We need to know where the tissue has been picked from, the site of the body where the tissue has been picked from, and the rest of the information is very important. So if more than one specimen has to be placed in the same container for the same patient, then they must be clearly marked, which is most readily done by means of sutures. So the surgeon or the person collecting these samples, the biopsies, can actually mark them out and they can be easily identified. So description of additional specimens received from the same patient must be mentioned, just in case there is any. You don't just put and bring, but it should be written clearly. So no tissue material such as blades, implants, foreign bodies should be recorded, as this should be essential in the medical legal process. So once you find such objects which are non-tissue substances, you make sure you report them. Don't just find them and then remove them and throw them away. But actually, when you see such materials in the tissue, you have identified the blade, then you pick it, keep it, and then record it. You need to do recording, because you never know if there are medical legal cases, then this can help you as evidence to possibly conclude the court case. So only labeled specimens should be accepted. The label should be firmly attached to the body of the container so that it cannot be separated. So before you continue with grossing, you need actually to compare. You look at the request form that you have, which is accompanying the container, and make sure whichever detail is on the container is actually matching with what is on the form, to ensure that you are actually having the specimen for the right person. Otherwise, you may mix up samples and give wrong results to wrong people. So specimen labels should not be attached to just the lid but the body of the container. So when we are labeling the containers, we need to label the body, not the containers. Reason being, when you're grossing, you may remove the lid and put it aside, but the container on the side, it will remain there on the side. So you can easily see the labels and identify your tissue with the request form, and then match them out and make sure you are actually working on the right sample. So incorrect identification of any specimen may result in wrong diagnosis and incorrect treatment to potentially to patients, and this will not be good. So in cases of the skin, then measurements of the skin surface dimensions and the depth should be documented. We need whatever you identify, actually you must document it, because at the end of the day it will be important information. So any tissue that is small enough to slip through the cassette holes should be wrapped in the processing filter paper or tissue paper, or a processing mesh bag. For labs which have processing mesh bags or tissue papers, you put these small parts of the tissue if they are received, because they may actually go through the walls of the cassette and get lost. So we need these tissues. Like for example, if you have received this scraping, sometimes they are too small. If you have received some cores, they are too small to actually be put in the cassette. So we put them in the filter paper and then we put them in a cassette. So you make sure you wrap them very well so that they don't go through. So tissue should only be inked if it conveys information such as orientation and margins in excision, or which side to be embedded down. So marking them with ink is important when we want to communicate. One, you want to communicate on which side should be put down during orientation, because the side we put down, that's the side we want to actually face the blade first when we are doing our sectioning. Or we may label the margins still to communicate to another person who will be involved in tissue processing and possibly in embedding and the sectioning, to know that this is margin and this is how the tissue should be oriented. So that's only when we should not just put the ink, but the ink should be purposefully put to communicate something. So usual skin surface or pigmentation should be noted if you identify it. So thickness of the specimen, like for example, a uniform thickness of the specimen is an obvious requirement for processing, but it is difficult to achieve under conditions of insufficient fixation or inadequate hardening of the specimen. So we need to ensure that the tissues are processed well. So the tissue thickness should ideally be 2 to 4 millimeters in thickness. This would be ideal for easy penetration of the fixative, and even during putting the tissue in the cassette, it will fit properly in the cassette without getting out, and to enable even the cassette to close properly. If it is much of the tissue, the cassette won't close properly, and during the process they may even fall off. So we need to put small pieces of the tissue so that they can fit well in the section and can be processed right away. So under no circumstance should any portion of the specimen be discarded before the case is signed out, because what you discard may actually be the portion of interest which may be required to make a diagnosis of interest. So don't throw away any piece of the tissue, not until we conclude or until you conclude the case. So we need to look at safety during process. You remember we are dealing with corrosive chemicals, we are dealing with the fumes, we are dealing with formalin, and then we are handling sharps which can easily cut. And again, we are handling infectious specimens. Remember, we are having tissues from possibly sick patients. So in as much as we may be looking at the malignancies, most especially, but these clients could be carrying out coming with other infections which could be dangerous. So all tissues must be considered potentially hazardous, and universal precaution must be taken when grossing the tissue. Number 2, formalin fumes are also known to be health hazards, and it is a severe eye and skin irritant and is toxic by ingestion and inhalation. So this can be actually minimized by proper tissue handling, fixation of the specimen before grossing, and even proper use of personal protective equipment. You put on your mask, you put on your goggles. This will at least protect you to a certain extent. So adequate protective measures to protect yourself from infection must also be undertaken, such as use of disposable gloves, face masks, and eye gears. Then we can't forget to wash the hands so that we cannot carry the infection from the grossing station to other places in the lab. So grossing should also be done under a fume or a safety cabinet which is designed to extract formalin vapor. So it is advisable that we do the grossing under a safety cabinet which has the potential to suck away the fumes and reduce on our exposure to formalin fumes. So contact with chemicals also should be minimized, and the protective gear should be disposed of in a correct manner. We have talked and we have for some time discussed about infection control and waste segregation, different bins with the color codes, and this is what should be carried on even in the grossing room. You dispose of correctly the used gloves. So the laboratory personnel should clean all instruments and working surface with the disinfectant after use. You should not just keep, but you need to maintain you need to make sure that your equipment is clean before you really keep it. So we need now to get to the real procedure of grossing. What do we do, or what happens exactly in the grossing room? So number 1, the procedure, you need to assemble the requirements and wear your personal protective equipment, and this is very important. And just like any other place, if you are to do work very well, this has to be done properly. At least it's advisable you arrange and you assemble the material that you intend to use in place, so that you cannot keep on moving from one place after you put on your glove. That's when you remember you need to put on your clinical coat, and then you have to go and look for the lab coat. That really can't work out. So it is always better you arrange your things, you put your things in one place before you start the process. So number 2, you need to correspond the identifiers on the specimen container with those on the request form to make sure they match and you know you're handling the right specimen. Number 3, you need to make a general inspection of the specimen with identification of all its normal and abnormal components. That is very important. Number 4, microscopically, you need to describe the specimen by looking and noting features like a color, texture, dimensions, weight, shape, unique features like ulcerations, just in case you see them. You need to identify the skin if it's there, muscles that may be attached to the specimen. It is also very important that you identify them and you note them down. So continuing further, number 5, we need to place the specimen on the grossing board and orient the tissue in its anatomical position. When we are going to gross, I will give for this presentation, I've used the breast, and then I will continue actually giving the same example. So if you have a biopsy, you have a specimen before you, and for this case it is a breast, so you need to put it on the grossing board in its former anatomical position so that it appears as if it is still on its original body before it was removed. That's what we mean by the anatomical position. So you orient it on the board, and this will help you to identify the different margins, the superior, the anterior, the lateral, and then to describe it will give you a proper description of the tissue. Now for example, like the breast, you need to even mention whether it is really a left breast or it is a right breast. Number 6, the identification markers for orientation, such as the sutures, must be carefully considered. Look carefully at these sutures. Are they short? Are they small? If it is long, in most cases, this will actually be pointing at the lateral side, and if it is short, it will, in most cases, it will be identifying the superior margin of the breast. Number 7, you need to look at the surgical margins, and this should be identified correctly after orienting. So when you orient your tissue very well, you can be able now to identify that this is the superior, this is the inferior, and this is the posterior, and this is the anterior, when you have properly oriented your tissue in its anatomical position. Number 8, photographs of the specimen can be taken before it is dissected. So, cameras, after you have oriented and placed your tissue on the grossing board, oriented it well, so you can take pictures, you can take photos, several of them from different positions to capture almost the 3D representation of the tissue you have. I think we need to correct some of this mistake here. This is supposed to be to reveal. So number 9, we were saying that the pathologist must use sharp cutting instruments, and this is done to avoid artifacts, and then cut through the specimen to reveal the inner parts, or what we call the cut surface. And we also need to describe the cut surface, its color, the texture. It could have some macroscopic features of interest that may actually lead us to identifying our diagnostic parts of the tissue that we may cut out and continue further for other processes. So the macroscopic description of the cut surface is then noted, so we do not just cut, but we need to describe what we have seen. So if the cut surface contains a tumor, its deception-like color, texture, and dimension are noted. Whatever you have seen in the cut surface and they are suspicious of being a tumor, you write them down, you describe whatever you have seen. So you describe if there is change in color, it is creamy, it is white, you describe, you suspect, or you're seeing some necrotic part or caseous part, you describe whatever you have really identified. Number 12, photographs of the cut surface are also taken. If you open up the tissue you cut it through, it is important that you also take the pictures when you have the cameras incorporated in your procedure. Then you need to take pictures also of the cut surface. So orientation will determine the depth of invasion of the lesion and the margins of resection. So this is very important, that when you orient your tissue very well, you will be able to determine the depth of invasion of the lesion. And when we look at the depth of invasion of the lesion, it helps us to determine and do the staging, proper staging of the cancer, depending on how it has invaded other neighboring organs. So number 14, the specimen is then sampled to make a representation portion of the entire gross specimen. So in this, we must always ensure that whatever we pick out of the entire specimen that we have must be representative. We cannot have the entire tissue to be taken to the cassette, but shall have a portion of it, and whatever you have picked must be representative of the entire tissue we received. Like we gave an example in the beginning, we have been using an example of a breast. So in this case, whatever portion of the breast you pick, it must represent the entire breast. So we take precaution and make sure we really sample out the best part, which will be diagnostically significant. So the sample tissue is then placed in a labeled tissue cassette, marked very well and then labeled, because we need to identify them. So for some big tissues, like for example the tissue we have given as an example, the breast, we pick a number of representative parts of the tissue, so that to make sure, because the tissue is big, the breast is big, so we may need to pick at least a sample from all the margins. Yes, we pick from all the margins, so that we not pick maybe one, but we may pick two, we have a number of them, so that we may not miss out, and we have to examine all these parts from the tissue that we have really sampled. So the sample tissue should be at least 2 to 4 millimeters in size, and we say this is good because it can fit well in the cassette, and then for easy penetration of the fixative, so that it can be preserved well, because we don't want to lose out any of the tissues as a result of mishandling. So the tissue cassettes are then covered and placed in a specimen container, which will be containing 10% neutral buffered formalin, ready for processing. And then the working area and the instruments are then cleaned after grossing. We don't leave our working station dirty, but we go ahead to clean. So there are points we need to note. And what we need to note, number 1, is that at no point should the tissue dry during grossing. So that's why after we have cut out our representative tissues, we put them back in formalin. We don't leave them on the table to dry out. So we do not leave tissues on the surface, or we don't leave them out to dry. They must be always kept moist. Number 2, contamination of the specimen can occur anytime during the handling of the specimen. Like for example, floaters can contaminate, cutting board metastasis, which must also be carefully eliminated. And this will be done by washing the cutting tool or the cutting board with running tap water before cutting another specimen. We may reuse some cutting equipment like the knife. So after using the knife on this breast, you have probably used it to bread loaf. So it is advisable that you clean it thoroughly before you use it on another specimen. And maybe, if not maybe, but the grossing board should be actually cleaned from tissue to tissue, because you don't know which tissue actually has cancer, but now we are just suspecting. So some portion, some micro particles of the tissue can remain on the board, and then you put another tissue and it can cross over, and you may actually in the end a person who doesn't have cancer may actually be diagnosed with cancer when it was actually as a result of not cleaning, and it came from the board, what we call the board metastasis. It moved from the board into the tissue of a negative person, and this person is diagnosed wrongly and declared to be having cancer, which is not actually proper. So tissue samples dissected from the main specimen should be immediately placed in the tissue cassettes with the surfaces to be sectioned facing down. This is very important. We need to make sure that the surfaces which are going to be sectioned are put downwards so that it is embedded correctly. So when you get a cassette and you're going to embed this tissue, it is good always to maintain the position or the orientation of the tissue as it is in the cassette, because we need that surface to be sectioned first. Is our portion of interest that we need to look at. So we have two images here with the different illustrations. So the image on our left, we can see cassettes which are overloaded, and with this overloading, one, we cannot actually close the cassettes, and the tissues may easily pour out. You see, one part of the tissue is even out. This is not acceptable. So we should make sure that we cut small pieces of the tissue we can fit very well. And then the orientation of this tissue is also not right. We are seeing one pointing the other side, the other one, and then one lying on top of the other. And again, there are many in a small cassette, and the cassette may not even actually take all of them and not cover properly. And when it is not covered properly, we can easily lose out the tissue. Then on our right here, we are seeing cassettes which are literally labeled, but the labels are illegible. We cannot actually read, we cannot identify the number which is on this cassette. So this is going to cause trouble when we need to identify from which patient the sample in this cassette actually came from. You see, so this is not acceptable. We must label our cassettes with clear and legible identifiers so that we can quickly identify them and be able to relate them with what we have. So we have specimen orientation, and during grossing we have talked about this. So here we are looking at a tissue, or we are having a specimen that we have received in the lab, and in this below it we are seeing a ruler. This is a ruler here, and we know the use of this ruler. We need to measure this sample we have received, this tissue, the specimen we have. We either say it measures 5 by 6 depending, and then it is labeled, it is marked with the sutures from the theater. So right, we see this is a right breast lumpectomy which we received and is fresh, it's not yet fixed. So we can do grossing on this. We can see the color, how it is appearing, its size, its shape. So all that will be grossing. And then we have the suture identifications. So we have the long suture, which is actually communicating to us that this is the lateral. That is the lateral side or the lateral margin of what we have. We have this suture here, and this is the long one. You can see it is very long. And what is communicating to us? They are telling us, please, this one, this is the lateral, and then the short is actually indicating to us the superior margin or the superior orientation of our tissue. So we have a short suture here, which is actually indicating to us that this is the superior side of our tissue. So once we receive a tissue with such markings on our board on the grossing station, we must also orient it in a position in its anatomical position. So here we can be able to do the grossing very well. Still during grossing, we have another specimen here. here it is the same as this one, but now this one here we identifying the margins by painting using ink, and we can appreciate that we can see the anterior, which is actually painted yellow. We have the superior painted blue. I think the blue can be seen clearest depending on how sharp your eye is. Sometimes these are the intra-observer challenges we have. This may be mistaken to be black, but actually this is blue, and blue, this is actually referring to the superior. And then we have the anterior area, or the anterior margin, which is actually yellow, and then we have the posterior, which is black. It can be seen on the sides. Yes, the posterior is black, and then we have the inferior, which is actually marked red. So this can actually help you to orient your tissue in a mold when we are embedding, when the sides are really marked very well. So the same way we are seeing it here, we need to transfer the same orientation to the cassette after grossing, and then when we are embedding, it is important to maintain the same orientation. So the purpose of inking during grossing: 1, it helps to determine the margins of the specimen, and number 2, to indicate specific areas of interest to the pathologist. Number 3, it also important to indicate the mode of embedding it will guide. And then number 4, maintain the anatomic orientation of the specimen. These inks of different colors designating each of the 6 specimen margins that we have already talked about. And in these margins we are talking about the superior, we are talking about the inferior, the medial, the lateral, anterior, and posterior. So these ones must always be identified, and they can be ideally used to do this when we mark or when we paint our tissue with the different colors. So inking cut surfaces of the tissue with one color can also help in embedding to determine which surface should actually be embedded down. And this is very important because the surface which is embedded down will be the surface which will face the blade first, and the one which is exposed first. So where inked surfaces will meet the blade first during microtomy process, that is very important. So inking is also typically reserved for excisions, and inking margins on biopsies is not required since a second procedure is anticipated based on diagnosis of the biopsy. So other procedures may be required, and other tests may be actually even requested after the biopsy or after the macroscopic examination. Like for example, we may need to do immunohistochemical staining. So we talked about bread loafing or slicing, and this is what we mean. This was a big tissue, and when we just put it in the fixative, because of the size, you remember we talked about the factors which are affecting fixation, and one of them was size. So to quicken easy penetration of the fixative into the tissue, to ensure that every part of the tissue we received is properly fixed, we bread loaf, we cut or we slice the tissue into small parts to allow the fixative go through the tissue very well. So this brings us to the end of our presentation for today. I still want to thank you so much for taking your time to attend today's presentation. You please don't forget to like if you have not liked the page, and don't forget to subscribe. Kindly subscribe, and lastly, you share. Be good enough to share with your friends so that they can also benefit from these presentations. Otherwise, I'm glad you have come to the end of this presentation. I wish you the best of your day. Let's meet next time. Bye for now.